Okay, good evening, good morning, good afternoon to everybody. I'm Annie McCluskey, one of the StrokeEd team, and I'm pleased to welcome Emma Schneider, who I'll leave to introduce herself. We'll record the event today, and any of your colleagues and yourself can listen to the recording afterwards. Emma's asked if we can have questions in the Q&A box that you'll see at the bottom of your screen. If you have any general questions or you're having problems, you can put them in the chat. And remember, if you do have problems with connection, you'll be able to listen to the recording after this evening. Emma said that there will be a couple of times during the session where she'll talk and she'll stop and answer any questions, and there should be some time at the end. So I'll pass over to you now, Emma.
Thank you, Annie, and thanks everyone at StrokeEd. And then thank you for attending. If you're on the webinar live, welcome, and if you're listening onto the recording, thank you very much. So today I'll be speaking about cognitive rehabilitation models, summarising some of the evidence-based recommendations for adults with brain injury. I might be talking quite fast because we're going to try and squeeze in quite a bit of information, but I have included some links and references. For example, they're coming up in just a second. So first of all, in the spirit of reconciliation, I acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islanders people here today. As I mentioned, these are some key references that are available. So this is a paid reference. So the American Congress of Rehabilitation Medicine have developed a cognitive rehabilitation manual, which is down in that small photo at the bottom, which is around $150 US, but they also provide a number of training courses. Some of them are online and they also do face-to-face training. I think the next one is in Chicago, but they do run around the United States, and I think they also go into Europe. But do look at their website for information, and it is a great manual, and I recommend that if you work with people and you provide cognitive rehabilitation medicine to adults after brain injury, then it's something that you should have in your toolbox. This reference is actually one of the main references that I'll be using today to talk about the cognitive rehabilitation model. There's also a book chapter that's actually available. Julia and Jennifer have made their book available online. So you can actually search for this book and you can download it free. And I strongly recommend that you look at this text. It's metacognitive occupational based training, and it's very important in terms of some of the evidence that's been developed over the last, oh, hang on, what year is it? No, over nearly 10 years, particularly around metacognitive strategy training. This is another article that's accessible, and I think it's just a really nice summary to break down the model of cognitive rehabilitation. And again, you can look it up and hopefully access that freely. There's the reference there. So that's Stevens around cognitive rehabilitation after traumatic brain injury, a reference for occupational therapists. Okay. One final reference is actually a new book from Joan Toglia and Erin Foster. It's around the multi-context approach to cognitive rehabilitation. They also have a website that you can see on the screen, and that's a picture to the left of some of the resources or publications. They search around applying cognitive rehabilitation approaches, and I would recommend that you become familiar with it if you are not. Okay, so this is what we're going to be speaking about today. We're going to break it up into two parts. Part one, we're really going to look at those cognitive rehabilitation models and how you develop a treatment plan. And part two is around those guideline recommendations, which I'll be touching on. That could almost be a whole hour on its own. So bear with me, we'll go quite quickly. But as I said, I'm going to provide you with some references so you can go and do some more reading on your own. First of all, cognitive rehabilitation. Cognitive rehabilitation aims to ameliorate or just soften, so not get rid of those injury-related deficits in order to maximise safety, daily functioning, independence and quality of life. And this is really key. We are not trying to fix the actual underlying cognitive impairment through this rehabilitation that we're providing. We are coming at it from that occupational performance perspective. So if someone has had a cognitive injury, brain injury, and they have a cognitive impairment, let's say they have a memory impairment, The way that impairment affects their occupational performance and engagement may be that they can't remember to attend an appointment. They're forgetting their appointments and they're running late, and therefore they miss out on their rehab. So the goal would be around them actually attending their appointments and not missing their rehabilitation sessions. And that would be the strategies that we apply to increase that occupational performance. The underlying cognitive impairment will still remain, but it's about the performance. So that's the real key here. And when we're talking about assessment, which is coming up soon, it's important that we measure at the right level where we're expecting that change to occur. So the cognitive rehabilitation occurs over these two main phases. This first phase around assessment, treatment planning and goal writing, and then the implementation of that treatment plan. We're not going to spend a lot of time around assessment and goal writing, but we will talk about treatment planning and around the implementation of that treatment plan. It's important to note, though, however, that you shouldn't delay from moving into phase 1 to phase 2, and a program should be designed to continue to review. So you should go back, review the goals, review the assessment, make sure everything's working as planned, like we normally do with any kind of rehabilitation model, and modify and adjust as possible. And it may be that you have done an assessment and you've selected something in terms of the underlying cause of the occupational performance barrier, and it may be that they've got an attention problem. And when you start working on that issue, you might notice that they have another cognitive impairment that's having an impact. So then you'll have another goal relating to that. So it's a cycle. It's not just stage 1, stage 2 when you're done. It's an ongoing process. And I'm not going to talk about goal setting, but it's absolutely imperative, which we'll touch on throughout. As I mentioned, I'm not going to spend a lot of time talking about assessment, but like assessment, we're occupational therapists, so we're going to be looking at that person, the environment and their occupational performance. We are going to be aware of the cognitive impairment and the underlying changes to cognition, but where we're really going to be focusing on change, it's around the goal attainment and that occupational performance, how that all is done overall. So for example, we might want to be doing some global assessments of the person or environment, like a FIM or a SMAF, if you're aware of the French SMAF assessment. There would be a measure of cognitive impairment. So depending on the type of cognitive impairment, it might be a Westmead post-traumatic amnesia scale assessment, or an orientation log if someone's got an orientation impairment. Or you could be looking at a self-awareness questionnaire if someone has an impairment with their self-awareness. Or you might be doing a cognitive screen, like a cognitive assessment of Minnesota or an Oxford cognitive screen. Or you could be measuring occupational performance. There's a free test online called the Kettle test, which actually assesses someone's performance making a hot drink. There's also the PRPP, the Perceive, Recall, Plan and Perform model. That is a formalised process of occupational performance. And then, of course, we can just use our occupational therapy skills of task analysis and observation and looking at what areas are occurring and breaking that down to map it through to what cognitive impairment is likely underlying that. And goal attainment. So as I said, if you're actually applying a cognitive rehabilitation model, this goal attainment is where we want to see that change, because that's the measurable change. So you could be using a goal attainment scaling. So the GAS is a good way to measure change over time. Okay, so we're going to be talking about the 4 overarching principles of cognitive rehabilitation. And this is considered during that implementation of the treatment plan. So I said there were phase 1 and phase 2. We're talking now about phase 2, but phase 1 is still very important. Okay, so there essentially cognitive rehabilitation addresses these 4 key areas, and we're going to talk about them each one at a time in more detail. So the first phase of cognitive rehabilitation is to build awareness of that person through conversation and providing feedback. So we really want that person with the brain injury and cognitive impairment to start to understand that they have a cognitive impairment, what it is, and how it's having an effect on their occupational performance. The simple task of actually asking someone to predict how they will perform before they do a task, and then later review their prediction and provide feedback, honest feedback, objective feedback about how they actually did, is a simple strategy of building awareness. And we've got some evidence-based models for insight building through video feedback that we'll be talking about later on. It's also a really good opportunity to set goals and build rapport in your relationship with the person, and really help them engage in their therapy program, because obviously, if we don't have clear goals, if we're not clearly motivated for something, we're not going to put the hard work in and usually achieve that outcome. So it's around building this awareness, creating those relationships, and setting goals is the first step around that awareness. The second step is around compensation, and this is really where we provide those tools and strategies to overcome the impairment through the application of strategies. So this is where we see that occupational performance and engagement improve because we've put things in place, whether they're in the environment, the person, or through changing the occupation. We've put those strategies in place and therefore their performance is improved. So this compensation, as I said, it can be either internal strategies or external strategies. So internal strategies are in the person, which we'll talk about more, and external strategies are obviously outside the person, whether they're in the environment or another individual person as well. And they can be either, so I've got some examples here, and you might be familiar with some of them, and we're going to talk a little bit more about these strategies in detail. And it's important to note that there are several factors that you need to consider when you selecting the right strategy to use, which we'll also talk about as well. Internalisation, so through repetitive practice of strategies, in using those strategies in the appropriate scenarios, the application of strategies becomes automatic and internalised. So there's a less dependency on having a therapist or a person or the set of instructions. It becomes more automatic. They don't need as much support in that appropriate scenario within that goal that's being set. So it becomes learned. They use the technique that's been trained. So if there's been a goal to use an external memory aid, like a mobile phone for a diary or a calendar, they are now able to practice and use, putting the appointment in the calendar, finding the calendar in the phone, and actually responding to the prompt when the reminder goes off to say that you've got an appointment or there's a reminder that you have to do, and they can actually respond to that. So that's actually that internalisation of that process of using that strategy, which is the external memory aid of an electronic phone. However, depending on the severity of injury, the repetitive training can either be via an errorless learning approach, can either be strategic, meaning that they could use it in a variety of novel situations, so not just in the one hospital room or the one home or the one kitchen, but they can use it in anywhere that they go. So it could be for remembering shopping lists, it could be a strategy for remembering appointments, not just for therapy, but for meeting social friends, for, pretty much how I use my calendar in my phone. I use it to remember everything. So that's more of a global strategy versus a very task-specific singular strategy. So it might just be the steps to make a single sandwich, but we can't assume that that strategy would apply to then making a 4-course dinner. The next phase is generalisation. Apply that strategy that was learned, that specific context, to other everyday areas of daily functioning. And hopefully they can generalise the learned skills to a range of situations and tasks through that internalised learned strategy. And this process is completed through regular review of patient goals and the provision of ongoing feedback. And it's often through homework that it's also applied. It is really important to note that this 4th phase is not always possible for everyone. If someone has a very severe brain injury, it would be unlikely and unrealistic to expect that they would be able to learn to generalise the strategy. We'd need to focus on those task-specific strategies and not expect for a global application of that strategy that's been learned. Okay, so now we're just pausing again. So we had those phase 1, phase 2. So phase 1 is that assessment, goal, and then we need to choose strategies and develop a treatment plan. Phase 2 is around that application of cognitive strategies. So how do we actually go, okay, we know that they've got an impairment around their attention. We know that it's having an effect on them doing their schoolwork, or they're not able to attend to the computer to do their work on the computer to do their job. Finally got that sentence out. And we've chosen what strategies we're going to use. How do we actually deliver that training so they can apply them in those phases of learning. And it's through these 3 phases here, that acquisition, application, and adaptation, where you teach the use of that compensation strategy. Okay, so we're going to look at these now. So acquisition, it's like any kind of thing that you would do when you learn something new. You need to learn how to use it, how to use it well, and the procedures of using it. So as I mentioned before, if we were going to be teaching someone to use an external memory aid, like an iPhone or an iCalendar or Google Calendar, you have to first understand why you're using it and what for. So the clear cues around when to use it and when not to use it, and the procedures for how to do that. They need to recognise and accept that they need to use it and the benefit of actually doing that. So they need to then maybe learn how to charge the phone, how to make sure that they have the phone with them, that they can actually open the calendar feature on the phone, they can enter the calendar appointments, and then of course they can respond to the calendar reminder if they do need the reminder, or they know that they need to go in and open the calendar to see if they have any appointments that they need to then how to use the strategy that you're actually teaching. Acquisition is the, whoops, sorry, there we go. Application is where we then help to use that strategy in that context. So we're improving effectiveness and independence in compensating for the deficits, and it's helping to internalize those strategies. So in the first phase, it's very heavily dependent on those external cues. I didn't say it, but over here in the final box on the right, it said external only. So we're just giving information, giving instructions. They might be verbal instructions, they might be written instructions. It depends on the individual. Where we're moving to application, this is where we're using that strategy in the context. And then we can use both internal and external cues to help promoting that use of the strategy in context. So hopefully it's around that strategy mastery. So when you don't quite need to ask for help anymore, you're feeling like you can do it on your own, you can check that you're using it right, and you can modify your behaviour if you're not doing it correctly. Or where needed, you might need someone to help you still, depending on the severity of injury. So adaptation is the final step in this 3-stage, and adaptation is to try and promote that task transfer of training to tasks that are less structured, more novel or more complex or distracting. And again, we're aiming for a generalisation of skills. And again, you can use both external and internal cues. So any task that was previously performed in a structured therapy environment should now be attempted to be done in a less structured environment or outside therapy, often in the community. So it's especially important for those transitioning out of inpatient rehab or hospital-based rehab to home-based or community-based rehab, that they get practice before they transition. So if someone isn't great at transitioning their skills, then a lot of work would need to be done before someone moves from a hospital-based system to that new environment that they're moving to. Okay, so we've spoken a bit about cognitive rehabilitation. Now we're going to look at models for treatment. And there are 2 main models that I'm going to speak about today. And one is from the American Congress of Rehabilitation Medicine. In the manual that I mentioned at the start that is available for purchase, or you can attend the training and get the manual as well, is a decision tree around looking specifically around, does that person have awareness of deficits, yes or no? And if they don't, we need to build that awareness, but we still move on with the process. So we don't need to stop. If someone doesn't have awareness, you don't just stop and keep staying in that phase, you still move on and you continue to build awareness throughout that process. Then you need to think about how severe is that injury. Can that person use a problem-solving strategy or a formal step-by-step instruction all on their own or not? How much help do they really need? So it's really looking at the level of injury, the severity of the injury, whether it's more mild or moderate or more severe. And then you can see here, this then helps us think about how are we going to deliver this in terms of achieving the goal? Is it going to be very task specific, i.e. I'm going to teach you how to make a sandwich. I'm going to teach you how to put your shoes on. I'm going to teach you how to catch one bus from point A to point B? Or is it going to be more general and global? I'm going to teach you how to get showered, dressed and make your breakfast. I'm going to teach you how to catch the bus and plan your trips to go anywhere. So do you see how they're very different things? And task-specific protocols are very procedural. Essentially, how you learn how to ride a bike, how you do things they can only be done the one way, the right way. And then those general approaches, as I said before, they've got that more overall domain. And again, it's whether or not we use the internal or the external strategies. And as you can see on the slide, for more severe injuries, we'll be looking at more of those external procedural learning, which is where something is practiced in the right way so frequently that it just becomes automatic, so that you don't really have to think about it. It's just a procedurally learned task. Whereas if it's someone with a more mild or moderate injury, it can be more of a metacognitive skill, which is what we all hopefully should be doing. We should be checking and thinking, planning, predicting, modifying and changing the way that we're doing something based on our overall goal, and a review of our performance and then modifying things. Okay. The next treatment planning model is around Tessa Hart. She's actually a neuropsychologist, and she spent her career working with people with acquired brain injuries and their families, and she's built a lot of resources. And if you actually look up the Moss Institute for Rehabilitation, which is down on the bottom of the slide, you can look up some of the work that the Moss Research Institute has actually developed, which is quite a lot. And this is a model around where should the source of change be. So remember, is it in the person, is it in the environment, or is it both? And is it around a restorative treatment? Are we trying to help that person overcome, maybe with more of those metacognitive strategies? Is it a compensatory treatment? Do we need to just put a patch in terms of modifying the task, modifying the instructions so there's something there to support? Is it physical? Can we simplify the space, simplify the demands, or do we actually need someone actually physically there to provide the cues? And so this is a really nice way of considering how we want to approach the treatment and think about the sustainability of the treatment. So we can't go ahead and go, I'm not going to go ahead and say the source of change is going to be a social caregiver if we don't have that resource that's available long-term to deliver that intervention or that compensation. So we need to really think about this. And even if you're in an acute setting or a hospital setting, you need to think about how a strategy might adapt to a longer term. If someone then moves out of the hospital, which is the goal, obviously, to go home, we need to be thinking about how can this be adapted and modified for the longer term. I'm sure people in the community are really familiar with thinking about how sustaining strategies can be over the longer term. Okay, I'm just going to check. I don't think we've got any questions in the Q&A. I think we're okay to keep going. Yep, okay, great. So we've spoken about cognitive rehabilitation and we've spoken briefly about models. Now we're going to think about those cognitive strategies and approaches. So first we're going to look at compensation strategies, which I said we'd come back to. So internal strategies. I think this is a really interesting point because I don't know about you, but often when I've worked with someone who's had a brain injury, which I've done for over 15 years, mostly in inpatient settings and always with adults, and I've worked with people within Australia and the United States, when I've asked them, how did you used to remember things? What strategies would you use? And no one would know what to say. They would always just go, well, I always just remembered. Or some people would be quite critical and say that they couldn't remember anything. But these strategies, these internal strategies, are actually commonly used by everyone. And now hopefully that I've got some examples on the screen, you're sitting there going, oh yeah, that's right, I do know that. How we remember the alphabet. If I said what letters after Q, you'd probably have to do the whole song to figure out what letters all that go one after the other. You've got elaborative rehearsal. I personally am not very good with remembering names, so I really have to try and use this one when I meet new people to help me remember someone's name. I need something to put together with that name so I can recall it. And I often, in terms of when I do my shopping list, I often chunk, or I use something called that's more around the thinking about the environment or the location of things, the method of loci. And I think about where I have it instead of actually writing a list. So I know I have to go to the fruit and vegetable section, the dairy section, the bread section. And that's something that how I help to remember things. And then, of course, there's other things that we can do externally. So if I need to remember to take things to work, I pack my bag and I leave it in one spot, you know, where my keys are, so I know I can't forget it. So there's lots of compensation strategies that we can be using. Of course, I kind of gave an example of, but these are really aids that provide cues or store information, or it's actually a person. So we've got commonly diaries, whiteboards and calendars. I think it's fair to say smartphones are pretty standard for most people. I think it's going to be quite interesting to see as the population continues to age and technology becomes more and more used, that it's going to be even more common in the long run. And I think it's also a tricky one to keep up to date with, because there are a lot of apps and resources that are available, but it can be quite challenging to keep up to date with all of the resources. And it's actually being recommended somewhere, I don't have the reference, but that someone actually takes responsibility and becomes an expert in that area instead of each person trying to be great at lots of different things, because as I said, things change over time. And one issue with technology sometimes is, I don't know if you've found this yourself, but I'm an iPhone user, and you know, every few weeks it seems at the moment they're updating their apps. And there was quite a big one a while ago, and everything looked different. The calendar looked different. It all kind of looked a little bit, it was different in the way that it was used. So if someone's, you know, not likely to cope with that change, then, you know, you need to make sure the phone's off to not update. So things that need to be monitored, usually by an extra person, not the individual themselves. Okay, so we're going to touch on errorless learning and error-based learning, because I've said it a few times throughout the presentation so far, and they're core components when delivering this cognitive rehabilitation strategy training. So hopefully you might be familiar with this already, or you might not be familiar, but errorless learning is really that process of learning a procedure or task without any error, and there's an immediate prompt to prevent any chance of incorrect response. So you need to use task analysis to break down the task that's being done. So for example, I worked with a man in an inpatient rehabilitation setting that had a traumatic brain injury. He had a frontal lobe deficit, so he lost his ability to kind of all of his executive functions in terms of initiating, planning and carrying out tasks. Even though he knew he wanted to stand up from a chair, put his shoes on, make his own breakfast, help take out the bin when he went home, he couldn't actually initiate his actions. So we needed to do task analysis to break every step down. So putting on your shoes, left foot, right foot, and we had to make the words and the steps. So it was all individualized for this person. And as it says here, cues can be taught through a variety of strategies. So this is a breakdown of errorless learning. So you, as I said, step one, that task identification, activity analysis. Then you select the appropriate method to present instructions. For this individual, because of his head injury, he actually had a vision impairment as well, so he wasn't able to read. So we needed to use verbal instruction a lot. Initially, it was all spoken by the therapist using errorless learning, and then he actually was able to learn that script. And he used self-talk in the end to stand up from a chair, instead of have been waiting in the bed for about 15 minutes before he could actually get up. He was able to push, pull, doona back, push arms down, feet down, and sit up on the bed, and then count and stand up. And he used all of those strategies for every activity that he had to do. And then we also have error-based learning, which you might be more familiar, commonly known as pause, prompt, raise. But this is really a metacognitive strategy in terms of helping people understand and recognise errors and self-correcting. So again, you still need to do the task performance and have an agreed step-by-step process of what order the tasks are going to be done. I can definitely think back to situations where maybe I hadn't really done that task analysis at the start and I haven't had that conversation with a person, tell me what you're going to do, how do you think you're going to go before we started the task. Maybe they were a little bit impulsive and I was a bit rushed, so we just did it quickly. And at the end, I might say, oh, but you put the milk in the cup before you put the hot water in when you were making a cup of coffee. Technically, that's not really wrong because you've still got a cup of coffee with a white coffee. It still worked, but it didn't seem right. So I had to understand before they did that step whether or not what was agreed upon in terms of the order and the preparation. Because oftentimes, you get the usual feedback, oh, that's what I always do, or that wasn't wrong. So you need to have that agreement beforehand. And there's a delay of up to 10 seconds when the task's being performed. Obviously, if there's a safety issue, you would intervene earlier. And this is a flow chart of what that looks like in practice. So they make an error, you wait. If they do a self-correction, you praise. If they don't, you provide a generic prompt. Oh, is there something you need to do with the water? And then it becomes more specific. And then it says, wet your hair with the water. Obviously, this is an example of getting showered, but you can see that there's actually a process of self-correction. There's a great paper that is on the reference list, but take a photo of it now if you want to, that Tamara and her colleagues have done around thinking about use of error-based learning for people with severe brain injuries and looking at what's actually better in terms of the outcomes for the individuals. So they did a randomised controlled trial and they were outpatient or community-based people, mostly around Brisbane in Australia, and there were 54 people recruited and each person had an 8-week home-based program and they were 90-minute sessions a week, and participants learnt to prepare a hot meal for the first 4 training sessions, and for the last 4 training sessions they developed a set of multiple tasks or complex multi-step activities that was related to any goal or interest that the person had. So it could have been doing a household task, going to a shopping centre, or doing computer skills training. And it's a great paper because it breaks down the key differences between error-based and error-less learning. And they found that error-based learning really facilitated skill generalisations on a similar or a near task, but not far transfer tasks, so not tasks that were very different. So you can see here around that ability to generalise or not generalise these strategies that have been taught. So it's a great paper and it provides some really good cues for clinical practice. Okay, so then we've just got, I thought I'd pause here and just highlight around how it really works. So obviously the assessment part happened before we identified what the impairment was. We've done an occupational performance, we've assessed the environment, we've looked at the resources, and we understand what might work for this person. We understand their history about how they might have completed this task, what is appropriate for them in terms of their acceptance, and we've developed a goal. We've then selected what our compensation strategy might be, and in this case, we're going to use an external memory aid. And we're going to then use the error-based learning methods, pause, prompt, praise, to train that internalised compensation of the strategy. So that application and adaptation of that strategy. It's really important to note, though, we're probably going to use more of an error-less learning strategy when we first start teaching the person those first components of how to actually use that electronic memory aid. Remember, we first want to teach them how to turn it on, find the calendar and put the appointments in. So we first need to teach that before we then start applying it to the activity that they're doing. Okay, I can see that there's a chat. So I'm just going to pause and say these are the general key messages from the first section. Annie, is there anything I need to respond to?
No, there isn't yet. No.
Okay, great.
And carry on.
So we are on time and we're probably going to have time for some conversations and questions. So the key messages around cognitive rehabilitation is that there are 4 key principles around building awareness, teaching compensation, building internalisation, and hopefully aiming for generalisation of that skill where possible. So remembering people with severe brain injury would be unlikely to generalise that skill. We've got, we teach these compensations through 3 stages around that: acquisition, application, and adaptation. Acquisition is always errorless learning. So I'm just teaching you how to do it because it's a new skill. Whereas those application and adaptations, that's where we use both internal and external cues. We use lots of different ways of either errorless or error-based learning. So that's around actually using that strategy that's been selected to overcome that cognitive impairment to then improve occupational performance and participation. So when we're selecting strategies, we need to consider impairment levels. We also need to consider what resources are available and the environment and what's realistic. And we always need to think about short-term goals and long-term goals that are important for the success of the therapy program. Hopefully this has helped present cognitive rehabilitation as a structured process. I think if maybe you're more comfortable, I certainly know as a clinician, I was a lot more comfortable with delivering motor retraining than I was at delivering cognitive retraining until I became familiar with some of these models, and it helped me recognise that it is a step-by-step process, and there are clear recommendations around how to design and develop and deliver evidence-based cognitive rehabilitation models.
I might stop you there because there is one question. Somebody's asking whether compensation and the strategies you're mentioning should be used together. And maybe you could give examples if that is the case.
Yes, that's a good question. And yes, the compensation is often around is actually a strategy. And it might be helpful for me to bring up another slide in a second, but the compensation is actually the strategy. So for example, as I mentioned before, if I might go back a couple of slides to here. So the compensation, so we'll just pause here again. So if someone's got an impairment, a memory impairment, but the way that impairment, that cognitive impairment is impacting on their occupational performance is that they're unable to remember their rehabilitation appointments and therefore they're running late. Or it may be someone in the community and they're unable to manage their busy calendar and they're late for another kind of appointment. So it's around that, the impact of that cognitive impairment. The goal is obviously for the person to be on time and attend all appointments without needing a verbal prompt, i.e. they don't need another person to help them be responsible. They can do it on their own. The compensation is how are we going to overcome that the effect of that cognitive impairment, in this case the memory impairment, and we're going to select an external memory aid like an iPhone calendar with reminders. Now and then we're going to then use the strategy to teach that compensation. So in this case we're going to first use errorless learning to provide the acquisition of the electronic memory aid. So remember, they first need to actually know how to turn it on, put the appointments in and respond to the appointments before they then start applying that strategy in the application phase to use it to actually respond to appointments and actually attend appointments using that calendar. And we're going to use an error-based learning method where there's some pause, prompt, praise, where we would get them to practice. We'd set maybe some fake appointments in the calendar and we'd get them to practice putting them in and actually attending to them. So maybe we could make some tiny little appointments like, go and buy a paper, go and get a coffee at 5 o'clock and, you can meet them there and see how they've gone. So that's how to build that internalisation of the compensatory strategy. And if we go to the next slide, if we think about that last phase in this stage of building that strategy, it would be adaptation. And ideally, we could then apply that strategy of using a calendar to attend to appointments to move to then social appointments, other appointments outside rehabilitation. It could also, if that person has appointments for their job, that their job involves making appointments, which most jobs do, they could then use that for that strategy for keeping track of those appointments as well. So hopefully that's answered the question. Were there any others, Annie?
Yes, just one more here about how you might apply compensatory strategies for somebody who's impulsive and or who perseverates.
Yeah, and I think this is common area. You know, it's unlikely that someone comes with just one cognitive impairment. It's usually a mixed bag, like lots of other injuries and impairments after brain injury. So if the you'd need to be factoring in other clinical, you know, usual practices. So if you're trying to reduce distractedness, then you'd be needing to think about the environment and minimise the distractions within that environment. And it's going to take probably a little bit longer, because if they're not getting some good attention on the task, then it might be more delayed in terms of the learning. Now, I know one was about, I think one of it was around impulsiveness, and what was the other one?
Perseveration.
So perseveration, again, we'd need to be working with some other team members to see if there are other strategies. So maybe they might be able to be redirected with a cue. Maybe it's a verbal cue, maybe it could be a visual cue. What would work for that person individually in terms of their ability to attend and focus on a task. So I think it's about breaking that down a little bit more. Just because someone has any of those cognitive impairments doesn't mean we shouldn't be trying to continue to move through the cognitive rehabilitation model. It might be just around adapting how we approach some of those strategies. And again, occupational therapists are not the only discipline that deliver cognitive rehabilitation. It is an interdisciplinary area where we all need to work together in terms of, obviously, if we're getting someone to do errorless learning, it needs to be repeated the exact same way every single time. So whether it's with myself as the OT, with the allied health assistant, with the care worker, with a family member, with a nurse, with someone else, then we need to make sure that there's clear instruction provided to that all of the people involved. And if they are going to be required to deliver that strategy, then that we collaborate to actually make sure it's sustainable and achievable before we start asking people to do things.
I've just got one more for you, Emma, and then I'll let you continue on. A very good question. You've just mentioned multidisciplinary practice. So Kath in New Zealand's asking, would you use this approach with somebody who's got apraxia? And you talked before about somebody who couldn't get up off the chair and couldn't organise their dressing, which sounds very similar to me.
Yes, and I think that's question specifically about apraxia. I think there are some evidence, and I think you're going to find some of the next references in the next section quite helpful, but there is developing evidence around apraxia, and it definitely looks at errorless learning and task-specific learning and some of those compensatory strategies. So it is definitely within this general principle around awareness, compensation, internalisation and generalisation, and selecting the right strategy and teaching it in the stages. So yes, it is still applicable. Okay, so just with time, I will go on to part 2. So now we're going to be talking about the guideline recommendations. And the good news is that there actually are a number of guidelines available. As I mentioned already, the American Congress of Rehabilitation Medicine. There's also a Stroke Foundation, the Australian and New Zealand Stroke Foundation. There's the INCOG recommendations for management of cognition following traumatic brain injury, and then the American OTA practice guidelines for adults with traumatic brain injury. Here are some references. So the ACRM, they're obviously purchased. The AOTA guidelines, the American guidelines, need to be purchased as well, but you can often find some of the articles that are referenced. And INCOG, they're published in journals. So they're published in the, you can see here, there's one at the bottom, the Journal of Head Trauma Rehabilitation. And they come in, I've only referenced part 3, but there are actually 5 parts, and I have included them in the references, I'm pretty sure. But if you look up INCOG recommendations for management of cognition following brain injury, you should find them. And as I said before, there are 5 parts to that resource. Now, I think I'm just double checking here. Oh no, I have put them all up, so that's good. There we go. All the ones that are relevant for this talk anyway. Okay. So the other thing to be aware of, if you're not already, is that there are some algorithms or processes. So the American Congress of Rehabilitation Medicine, there was a decision tree that I put up earlier. Within the manual, there are decision trees for every domain. So, for example, attention, executive function, memory, and so forth. And also INCOG also has a algorithm for decision making around what to deliver in terms of what the evidence-based recommendations suggest. So they're great resources that if you're not familiar with, you can become familiar with them. So the next thing we're going to talk more specifically about are some examples. We're going to talk about first an overall summary of guidelines that are recommended by the ACRM, the American Congress of Rehabilitation Medicine. So you can see here for memory, we've got some of those metacognitive internal strategies that we touched on before. And then also the external memories are around those memory books that we spoke around before as well. So attention, so there's metacognitive strategy training. So the ones that are mentioned on here, NBAC, time pressure management training, they're more neuropsychological strategies that would really target the actual attention impairment, which will make sense when I come to the attention slide. But we actually, as occupational therapists, we need to be focusing more on occupational performance and how we're going to be using those strategies within the task. And you can see that here on the slide. I'm just going to go, we're going to look at each of these in more detail. So executive functions. This is an area where there's actually quite significant, strong evidence in terms of there's lots of systematic reviews, there's lots of randomized control trials. And as you can see on the slide, this metacognitive strategy training comes up repeatedly. And there's some really good resources around there. And if you remember at the start of the lecture, I gave some key resources around metacognitive strategy training, metacognitive cognitive interventions. So there's some great resources out there. As I said, one of the textbook chapters is free and available online. So you can see here that this metacognitive strategy training should be focused on these everyday problems and functional outcomes, and it involves self-monitoring and self-regulation. And another big factor around executive functions is Julia Schmidt's resources around this video feedback, which is, I'm going to just move to the next slide because it's got more information on it. Just one second, there we go. So this is Julia's paper. Julia ran a randomized control trial where she used video feedback to build self-awareness with individuals after traumatic brain injury. They were in a hospital-based setting at the time. But this paper, I strongly recommend that you access the paper. It includes a lot of resources within the publication. So there's an error rating chart and there's really good clear guidelines around how to deliver that self-awareness video feedback treatment. And if you're thinking, oh gosh, I don't know if I can give honest feedback to people, I'm worried about how they might respond to that feedback, there's evidence to show that as long as we're doing it in an objective way, where we're giving clear information and we're actually discussing it with that person, not just saying this is what you did wrong, there's actually no negative outcomes associated. It's like it is perceived to be well received. So it's really important that if you're not comfortable delivering this feedback about someone's performance, that is something that you need to change in your practice because there's strong evidence. Julia's paper talks about people making meal in the kitchen, like, pasta or spaghetti. We have modified it, and we haven't put it in evidence, but we've modified it in our rehabilitation centre here in Melbourne, where we actually used it with someone who was an excavator. So his job, he worked for himself and he dug ground out to build pools or, prepare land for building properties. And we actually used the video feedback resource with him. We actually got him to write down how he would go about a task. So we got him to step by step write out what he would do if he was going to a site and a job. We had him a map of the hospital. We told him where we wanted to put the pool. Obviously, we weren't going to put a pool in, and he had to map it out and measure it out based on the dimensions that we gave him, and then come back in and write up a quote for how much it would be to dig that earth up. And we videoed that whole performance using the strategies around the feedback that Julia's got in her paper, and then got him to watch it back. And up until that point, he had denied any impairment. He had poor insight, and that was what we needed to just break through and get him to see himself on the screen. So essentially you video someone on their own device preferably, and then it doesn't worry, you don't have to worry about consent. And then you watch the video back after, but there are also steps around rating errors. So the therapist rates errors and the individual also rates errors. So look at the paper for more information. It's a great resource. Memory. So you can see here there's lots of memory strategy training. Memory strategy training, whether they're internal mental strategies or external mental strategies, and that they should include instructional or metacognitive strategies. Again, this metacognitive word keeps coming up. There's 4 memory strategies, actually some good evidence for what to do, but it's only based on 2 systematic reviews, but there are also several randomized controlled trials. So if you look up the INCOG guidelines or any of the guidelines that I mentioned, you can find some more references around how to maybe break that down. And it really talks about teaching that internal compensatory strategies who have memory impairments, and that they generally do better if someone has more of a mild or moderate impairment. Remember, if someone has more of a severe memory impairment, we need to be looking at those external cues, not internal cues. Okay, now here is another slide that just summarises some of the evidence-based techniques or strategies for memory impairment from American Cognitive Rehabilitation. So hopefully these are becoming familiar terms now: external strategies or memory training strategies. So they're those internal strategies. Orientation notebook, we definitely used it. We worked with a lady who had been in a car accident, and she actually had a lower leg amputation, and sadly her daughter also passed away in the accident. She was in post-traumatic amnesia for a long time, so she wasn't able to remember the accident. And even though we waited until she was able to recall day-to-day information before we told her what had happened, but she wasn't able to remember. So we actually made her a memory notebook where we put some information in about, we put photos in about all of her therapists. We had a photo about her. We put information about what happened to her medical history. We included the in memoriam pamphlet from her daughter's funeral, so she could see that it was in there. And we just sat and went through that. An allied health assistant supported her to go through that. And we had a strategy in place. If she was asking nursing staff or someone else what had happened, then we got the book and we taught her to go to the book for the answers, not ask the people. So over time, she was able to recall that information. This PQRST strategy, it's actually for how to help people manage technical information. So it's almost like what what you might have had to have done it in English when you're at school. You have to read the information, get some questions about it. Did you actually read the story? Do you understand what happened? State it back, and then you get tested on if you actually understood what the information was. So as I said, that might not be really that practical for OT, but it's a good strategy to know that it's evidence-based. Attention. So remediation of attention during post-acute rehab should be part of usual practice. There's strong evidence here in terms of grade A evidence, practice standard. If someone has an attention deficit, we should be doing something about it. And as I said before around attention, remediation should be part of usual practice, and treatment of attention deficits should include direct attention training, which is what I said before around some of those specific neuro cognitive interventions, and strategy training within that task. And it's got here around that training using everyday activities should be considered, especially in patients with mild or moderate attention deficits. General factors, so treatment starts with relatively easy tasks and gradually becomes more challenging. They should be individually tailored. There should be an emphasis on feedback and discussion, and there should be practice to apply the strategy in varied and flexible activities. And there's no one size fits all with attention. Hemi-spatial neglect. Now, this is an area where I think there has been quite a lot of thought around computer-based skills and pen and paper stuff, but it actually doesn't help. And that's the same thing with attention. and memory. Doing paper-based activities does not help. Remember, they need to be functional, task-based activities to get the best benefit. And I've included Mary Warren's name up here because she's done some amazing work. She actually runs some low vision assessment and rehabilitation for field deficits. There's the brain injury visual assessment battery, and if you go to the website, the MedBridge Education, she's an occupational therapist, and she's really fantastic. I would encourage you to look there for information. I'm just going to pop the key messages up, and then I'm going to jump to Annie.
Okay, Lauren's answered one of the questions about any research on dose of cognitive rehab recommended, saying that she wasn't aware of any specific research, but it was important to support generalization and use a repetitive approach. Do you want to comment anything more about dose of training? Especially in
unfortunately, so my PhD was on the dose of practice of motor activity training, and there is clear evidence around the dose of motor training. Unfortunately, there isn't clear evidence around the dose of cognitive training, but each study has really delivered. So you really need to be going to the randomized control trials to look at how much dose was delivered for the interventions delivered. So for example, I think I mentioned Julia Schmidt's paper around the video feedback model. They did, I think it was 4 sessions a week. I can't remember, I'm sorry, off the top of my head. I know they did multiple sessions, and that's how they measured the effectiveness of that intervention program. As I said, I kind of modified it. I didn't do it with cooking. I did it with one person, and we did it once and we got a huge change. And that was enough for us in that clinical setting to go, okay, now we're going to move on with other things. So as I said, there's not clear evidence around the dose for individual tasks, but I think overall there definitely is a challenge in rehabilitation programs accepting that someone might need cognitive rehab if they don't have a physical deficit. So there is a need for this space, yes, to be filled.
Yeah, I think probably the dose research is behind in terms of research compared with motor training, you know, but it probably will come, we'll probably see that. Now I'm going to move on to a different topic. There's a couple more questions about compensation, but somebody's asking about, you mentioned building awareness as the first step, but continuing with the process of cognitive rehab, if the person doesn't have awareness and continuing to try and build awareness, what about if the person is unable to build awareness? Is there any benefit in continuing that process?
I think that's a really good question, and I'm thinking about the community integration research and the community integration questionnaire is a really great resource as well. And I don't have it included in this information, but I just remember looking at some of that research, and they are able, and there is evidence to show that you can get someone to learn to apply a strategy and a compensation even if they don't have awareness. So remember, it's through that procedural learning. If someone has a very severe brain injury, they might not ever gain awareness. It might not be possible with the type of brain injury that they have, but they may be willing to follow the steps and complete the activities to learn the procedural process of the task-specific training that you'll address in your cognitive rehabilitation strategy.
Okay. Somebody's asking what you think about the Braintree, the brainwave program.
I have attended the Braintree program, and they one thing that I really took away from it is they had a nice little model around all the different types of cognitive skills like attention, memory, and they provided a guide around, you know, you need to start with attention and then you can move on to, you know, memory. And I'm probably getting it wrong because it's been a while since I've looked at it. But I thought that was a really good guide because, as we said before, you know, someone doesn't just have one cognitive impairment, they've usually got multiple things. And I think that's really helpful to consider what you might want to address first. I think for the Braintree training, there was a big focus on paper-based activities, and the evidence is quite clear that we need to be focused on activity performance applying strategies within task performance, not paper-based tasks.
Mm.
They may help an individual improve their insight, but there's a clear evidence now can actually improve insight. So I think that's where we want to focus as occupational therapists.
Yeah, Lauren's also commented on the limitation being a lot of pencil and paper tasks. Yeah. And I think as occupational therapists, that's been a big change over the last 15 years, is trying to move to functional training and generalization. We'll take another 2 questions, just in the interest of time. Maya's asking about the stroke guidelines having a weak evidence recommendation for various aspects of COG rehab versus the INCOG guidelines and the ACRM have strong evidence. I might just make a comment because I was involved, as Emma was, with the stroke guidelines here in Australia, and it partly depends on how the gradings are used. So in Australia, we use the weak recommendation basically is an international term that's used for where there might be quite a lot of evidence, but it's quite different. The trials are quite different in the way that they have delivered an intervention, and the outcome measures might be quite different, and the outcomes might be quite different. So we can't be confident about the results, hence the term a weak recommendation. We can't be confident about the outcomes that we would get with patients. So maybe you can comment, Emma, on the other ratings that are used.
Yeah, and I think there's strong evidence, even if there's only one randomized control trial. So there's definitely, like Annie said, there's definite differences there. And I think objectively, the evidence for cognitive rehabilitation for people with stroke is not as broad as the amount of evidence there is for cognitive rehabilitation with people with brain injury, mostly traumatic brain injury. So I think that's why there's a clear difference in the guidelines. And I think from my background, I obviously work with people with brain injury, whether that be traumatic or stroke. I have always just the same in terms of cognitive rehabilitation, even because obviously there's that gap in the evidence. We need to apply the best evidence, and I've usually gone about it that way.
Okay. Somebody from Malaysia is asking, is errorless learning more suitable for more severe cognitive impairment, low tolerance of frustration, or higher extrinsic locus of control?
Yeah, so errorless learning is definitely more suited for someone who has a more severe deficit or a big, a significant brain injury. And I haven't spoken about it because there's a lot to speak about, but like any kind of occupational performance task, we would want to modify the activity, the environment to make someone as successful as possible. So they would, there's less opportunities for frustration and failure, because obviously that's not enjoyable for anyone. We don't really want to do something that's hard and difficult. It's not meaningful, and you're not going to get good engagement and opportunity for training and practice. So it is definitely there. And then you'd probably just want to be like going to be appropriate, that's not going to irritate them, and that when we give cues and feedback, we don't use a tone that's demeaning, and that we use language that's appropriate for their age. So you don't go, good job, well done. It's actually appropriate for that individual person.
Yeah. And the last one I'll take, Lauren's, I think, answering this, but any advice about visuospatial functional training for people in a hospital setting?
Yes, and that's a fantastic question, and I would hopefully they saw the slide that I put up around the training resources for Mary Warren. So Mary Warren, if you look at her website and look at some of the papers, feel free to email me and I can provide some other references if you need them. But there's some really good clear references around thinking about occupational performance in terms of how we can modify and adapt the environment. Because obviously we can't change someone's visual impairment, like if they've got a loss of deficit. Obviously with neglect, we can try and build some awareness around the attention, but if they've ultimately lost vision in part of their eye, that is not coming back. Similar to if someone has a cognitive impairment, we can't assume that that's necessarily going to come back. We need to overcome it by putting strategies in place and compensations in place.
Great. Okay, thanks very much.